My name is Gert Mayer. I'm a nephrologist and I work at the Medical University in Innsbruck, Austria. I'm also the coordinator of the Horizon 2020 funded project DC-ren, which stands for drug combinations for rewriting renal pathologies in type 2 diabetes mellitus. So clearly the focus of the project is type 2 diabetes mellitus. And we are focusing again further on kidney disease in these individuals, which is a very prevalent comorbidity and a very serious comorbidity. It reduces quality of life and life expectancy, and because treatment is quite expensive, at least in the later stages of the disease, it also puts an enormous socio-economic burden on society. Fortunately, during the last years, several new drugs have become available that are able on a cohort level to either prevent or slow the progression of the disease. However, if you look at the individual data from individual patients, you see that there is a huge inter-individual variability in treatment response. This graph is from a study where they tested renin-angiotensin inhibitor therapy in patients with type 2 diabetes and looked at the development of renal function under stable therapy over several years. And what you can see is that in some individuals, renal function got better or stabilized under therapy, whereas in other individuals, despite therapy, renal function deteriorated. And the indication is that this is a reflection of different pathophysiology between the individuals, because otherwise you would expect uniform effects of therapy in everybody. So there is inter-individual variability in treatment response. This problem is tackled by many other research groups as well, and we decided that we have to go one step further. Because even if you look at the long-term effect of therapy within an individual, you again see heterogeneity. This graph shows you a group of individuals that we selected from a study that received stable renin-angiotensin system inhibitor therapy for 5 years. And during the first 2 years, and they were deliberately selected for this feature, these individuals lost 25% of their kidney function, which is a large amount. And you would argue that treatment does not work in these individuals. However, if you look at their course over the next 3 years, you see that in most of them, kidney function completely stabilizes or improves, which is contrary to the first 2 years. And again, if you think in pathophysiology terms and in treatment efficacy terms, you would say that most likely pathophysiology changed over time, making them now amenable to therapy, and those individuals that did not respond during the initial phase of the observation are now called responders. So there is not only inter-individual variability, but also intra-individual longitudinal variability of treatment response. And we try to cover both in our project. Conceptually, in order to develop the models that will help us to predict the course of the disease under specific combination therapies, we access ProValid, which is a large prospective cohort study in more than 4,000 individuals that we recruited in 5 European countries and followed for many years. And we have data available at baseline and annually thereafter. And we not only have the data available, but we also have available the therapy that these patients received, and we also have biosamples available that we can profile with a targeted or high throughput approach to better get an idea about the pathophysiology state that the patient is in. These models, once developed, will be validated in a set of other studies like SONA, Priority, or Canvas, where on top of RAS inhibition therapy was added an SGLT2 inhibitor, a mineralocorticoid receptor antagonist, or an endothelin receptor antagonist. And again, this will allow us to validate the models for their credibility. The final goal of DC-ren, however, is to develop a toolbox which will hold the most successful models, allowing us to predict the course of the disease under specific therapy, which will support the clinician at bedside to decide once all the information of the patient is entered into this toolbox, which treatment should be chosen. Clearly, this is not an easy task. And we need a multidisciplinary team, and we have collected this team, holding clinicians, experts in diabetes and diabetic kidney disease, as well as bioinformaticists, scientists involved in dynamic systems theory, and many, many others. And hopefully, by this combined effort, we will be able to solve the issues. I hope that you are interested in this project, and I would like to welcome you and to open the opportunity to you to have a look at the other videos of this series, where the partners will tell you their approach and how they try to develop these models. And otherwise, we will be very happy if you get in touch with us, either directly or via the website. So thank you very much for listening.